The Ghost Management Podcast with Marc-André Gagnon. Assistants Blue Miaorandong, Grace Duvacquet, Eric Mignon.
Episode 2, Ghost Management and Pharmacare. Hello, everybody, and welcome to our second podcast on ghost management. My name is Grace Duvacquet. I'm here today with my colleague, Blue Miaorandong, and today we're going to be talking to Professor Marc-André Gagnon, who is a professor at the School of Public Policy and Administration at Carleton University, and who specializes in the political economy of healthcare and pharmacare. Today, we're specifically focusing on the introduction of Pharmacare in Canada and what that might mean for Canadians, especially within the context of ghost management. Good morning, Dr. Gagnon.
Hey, Grace. Hey, Blue. How are you doing?
Really well, thank you. How are you?
Fine.
It's a great pleasure to have you back to our second podcast on pharmacare and ghost management, Mark. A lot has transpired in the world of Canadian pharmacare since our last conversation, and I must admit, I've been burning with questions. Are you ready to dive right into our discussion today?
Absolutely. I've been dying to dive into this question for the last 15 years or so. So absolutely.
Great to hear. Okay, so recently there has been a lot of talks that the federal government will introduce a new bill related to drug coverage. Have you been following on this rumor?
Yeah, absolutely. And this is important because what's happening on the Hill right now, so keep in mind, it's been a very long process, but the Trudeau government right now is supposed to introduce a new legislation to introduce a national pharmacare plan. Historically, the federal government wanted to do so since the 1960s, since the Hall Commission. Basically, we were supposed to have universal pharmacare. We had different commissions over time, always asking for implementation of universal public pharmacare for all Canadians. And since the arrival of Trudeau government, we had 2 years of consultation at the Standing Committee of Health that arrived with a new report in 2018 calling for the introduction of universal pharmacare in Canada. And after that, we had the Advisory Council for the Implementation of National Pharmacare, led by Eric Hoskins, that arrived with the last report in 2019, basically having a realistic roadmap in terms of how to introduce universal pharmacare in Canada in a prudent, maybe a slow but prudent way over the next 5 years. And the Trudeau government committed in 2019 to follow the recommendations of the Hoskins report. But with the pandemic, basically everything was put aside. And during the pandemic, let's just say the Trudeau government started to kind of grovel in front of the drug industry. You know, we had all these issues with vaccine procurement. And the whole issue of pharmacare was kind of left aside. And it's only last year there was this agreement between the NDP and the Liberals that, we will support the minority government in place only if they go forward with dental care and pharmacare. And they have to submit something by the end of 2023. So yes, the Trudeau government will go forward with a new bill normally before the end of 2023. Yes, they committed to implementing the recommendations of the Hoskins report, but at the same time, everything we saw in the last 3 years was going completely against anything that would be going against the interests of the drug industry. So a lot of people are kind of very concerned, worried that basically what will be presented will not be a real transformation of drug coverage in Canada for a universal pharmacare, but just something in terms of providing some patches here and there, fill the gap. The system is dysfunctional, and we'll just try to fill the gap in a system that will remain dysfunctional.
Okay, interesting. Let's back up here a second, though. Pharmacare in Canada is talked about as if it's kind of this this giant thing that everybody is assuming it's not an if, it's a when. It's something we need. But I think for our listeners, it would be helpful for us to talk a bit more about what you see as the key challenges and shortcomings in the existing drug coverage system in Canada. So what are those challenges, and how do those issues affect Canadians on a day-to-day basis?
So,
Essentially, why do we need Pharmacare in the first place?
and this is the most important question. And there's different reasons in order to support a universal pharmacare program. And, keep in mind, we can do this at the federal level. We can do this at the provincial level. It just, for me, doesn't make any sense that Quebec is not moving forward by itself with its own universal pharmacare system, for example. But the main issue is there's an issue of cost. We have a fragmented system, and with a fragmented system, there's always different ways to game this system, and we end up often with governments basically with this fragmented, very complex system that, instead of trying to contain cost for Canadians, end up as just passing the buck elsewhere in the system. So in the end, right now, after the United States, Canada is the place where the cost per capita for medication is the highest in the world. So basically, this is
Wow.
50% more than the OECD average. And the
Wow.
thing is, well, okay, we're paying more, but maybe we have better coverage because we have all these super generous private drug plans. But the thing, no, when we compare ourselves in terms of access, we still do worse than most European countries, for example, when it comes to access to medication. And we can measure that basically by looking at the number of people skipping doses, not filling prescriptions, something we call cost-related non-adherence, and it is way higher in Canada than in other countries.
Do you think Canadians would find that surprising?
I think so. It's just when we compare ourselves, it's just we perform so poorly. It's just people don't know about this. People think, oh, well, we just have some issues here and there. Just no, you're paying way too much for what you're getting. And so we end up with a system where you have stakeholders that can become very rich over this without providing any services or therapeutic benefits basically to the Canadian population. And this is why it is so problematic. But at the same time, this is exactly the reason why it's so difficult to get out of there, because you have all these stakeholders that benefit a lot from the dysfunctions of the current system. I mean, keep in mind, among developed countries, Canada and the United States are really the two countries where you do not have universal pharmacare. We do have universal Medicare in Canada, but Canada is the only country in the world where we have universal Medicare without including prescription drugs, as if prescription drugs were not an essential healthcare service. And that's a big issue. We're still organizing, thinking, designing access to prescription drugs in Canada in terms of privileges offered by employers to employees. That doesn't make any sense. And in fact, in order to provide incentives for employers to provide this type of coverage, what we do is we give them tax deductions. Basically, the costs you pay in premiums for your private drug plans, for your private health benefits, or your drug benefits, basically, is not considered to be part of your income. So the subsidies we give for that, we give these subsidies in a way that the richer you are, so your marginal income, the higher your marginal income tax rate is, the more subsidies you will get. And that's a real problem. So we have a system where we're providing incentives for private drug plans in a way that benefits the richest the most, when you have a lot of precarious workers that do not even have access to any drug coverage at all. And they do not get any of these subsidies. So that's a real problem here.
That's very interesting, considering especially the pride that a lot of Canadians take in the fact that we have universal healthcare, or so we believe. It's interesting to think about the fact that in Canada we don't seem to understand that universal healthcare means something very different in other parts of the world, and we're actually falling behind.
No, absolutely. Like I said, in terms of cost, we're paying like 50% more. And by the way, one of the province that is paying, in fact, the most is Quebec. I think this is like 66% more than the OECD average that we're paying per capita for drugs in Quebec. And by the way, Quebec is being touted, oh, this should be the model for the rest of Canada. I mean, yes, there's a bit of better access in Quebec as compared to other provinces. It's still worse in Quebec as compared to European countries, for example. But at the same time, it's just if we're spending more, this is something very important. Every dollar you spend is $1 in income for somebody else. So yes, a lot of the stakeholders, so the drug industry, the pharmacy chains, for example, would really like to see the Quebec model expanded to other provinces. But the Quebec model remains completely dysfunctional. Now, the other thing is something a bit more complex, but the lack of a national drug plan is also a lack of protection against predatory prices. So keep in mind that, I mean, it's been like 15 years more or less that the price game out there, I mean, not just only in Canada, everywhere, is based on confidential rebates. So drugs bring in these new drugs, new patented drugs on the market, and they arrive with artificially inflated prices. So these are the official prices, and then they negotiate price reductions, confidential rebates based on the bargaining capacity of payers. So first, in Canada, when it comes to the official price of patented drugs, we're second or third every year in terms of the highest official price. But the thing is, because we do not have a national drug plan to negotiate prices for the whole population, we do a very bad job at negotiating these rebates. So we have a higher official price and lesser capacity to negotiate rebates as compared to other countries. So in the end, that is costing a lot. But for many public drug plans that will negotiate some of these rebates, it's just, okay, well, we can contain costs for ourselves, but they will contain costs in a way that everybody else will be forced to pay the full official price. Most private drug plans do not negotiate anything in terms of confidential rebates. They take the official price out there. So that's, for me, one of the very important issues. If we want to do a good job in protecting ourselves against predatory prices, it's just we need to build up bargaining capacities, not just for some stakeholders in the system, but for the whole Canadian population, something we absolutely do not have right now. And maybe another point that for me is super interesting, because I've been talking a lot about cost, but it's not just an issue of cost. I mean, so let's keep in mind that universal pharmacare, based on the parliamentary budget officer, for example, based on very conservative assumptions, basically they say that would save Canadians 20% of their costs in prescription drugs. We're paying more or less $35 billion a year in prescription drugs, so we could save 20% on this. But like I said, every dollar you would save would be $1 of income lost for somebody else, and they will do everything they can to make sure it doesn't happen. So if we're talking $7 billion in savings. This is $7 billion somebody else will be losing. They will make everything they can.
And they're going to try and protect that.
Exactly. But my point here, I've been talking about cost a lot, but beyond that, it's an issue. Right now in this fragmented system, we don't even have the capacity to collect good data in terms of what is being prescribed. What are the prescribing habits? I mean, are the prescribing habits of doctors following best available evidence, or is this following the promotional campaigns of drug companies? And the thing is, if you have a system where most of the clients of the patients basically have private plans that say, oh, we will accept to pay for anything at any price. Well, you know what? Running huge promotional campaigns with doctors to get them to prescribe these super expensive drugs might work very well, basically.
Our system encourages it.
Exactly.
Our system encourages it. Yeah. Okay.
So, and maybe one fun example about this. Trintellix. So if you're taking antidepressant, now since 2016, Trintellix is on the market. Trintellix is a drug developed by Lundbeck. Lundbeck developed the drug Celexa at the time, and so in 1989. So an SSRI antidepressant. That was something new at the time, providing new therapeutic benefits. Celexa
this is kind of at the advent of the beginning of the SSRI craze, if you will.
Exactly. The first one was Prozac in 1988, I think, Celexa in 1989. But when the patent expired for Celexa, Lundbeck arrived with the new drug Cipralex. So instead of citalopram, it was escitalopram. We just tweaked the molecule a little bit. But in clinical trials, Lundbeck was not able to show any additional therapeutic benefits of Cipralex as compared to Celexa.
So it didn't provide a greater benefit to patients. It was essentially a drug that almost did the same thing.
Exactly. Well, there was no data to show that it was any better than the other one.
Right.
So many public drug plans at the time started to use what we call health technology assessment, making sure do we have value for money, and finally ended up not reimbursing the drug. Now, private plans all reimbursed this new drug, even if it was costing 5 to 10 times more than the generic versions that already existed. When the patent expired for Cipralex, we ended up with Lundbeck introducing Trintellix.
They did it again.
Exactly. Again, based on available clinical data, they cannot show any advantages of this new drug as compared to the existing ones. So, we have CADTH, the Canadian Agency for Drugs and Technologies of Health, reading the recommendation about, yes, for this Trintellix, you can reimburse it only if you obtain confidential rebates. Keep in mind, Trintellix is costing 10 times more than the other drugs that already exist. And you need, in the recommendation, they say, the drug plan cost of treatment with vortioxetine should not exceed the drug plan cost of the least costly antidepressant currently reimbursed, which is basically a bureaucrat language to say, this is crap. This is not bringing anything new to the market. Please don't pay a penny more for this new drug. But Trintellix arrived on the market in 2016. By October 2020, it captured 24% of the antidepressant market in Canada.
So despite the attempt to rein in the prescription of a drug that was not perceived or shown to provide any therapeutic advantage over existing treatments, it still captured the market, is what you're saying.
Exactly. And this is a huge problem. Then you can say, oh, well, it's okay if we're paying a lot for drugs because that will give more money for research and development, which, by the way, is complete crap. This is just more returns for shareholders, and that's it. But the thing is, if you have a system that accepts to pay for anything at any price, you end up with providing incentives for drug companies to bring crap on the market, basically. So,
Well, it doesn't sound like we're incentivizing innovation. If these drugs are not providing therapeutic benefits, what is that research actually producing? It seems to be producing drugs that don't actually advance the science.
exactly, and we call this normally Me Too drugs, basically drugs that is just repeating what other drugs is doing, but we simply run a good promotional campaigns and change the prescribing habits of doctors accordingly. Call this Me Too drugs. Let's keep in mind, you do have some Me Too drugs, for example, that do provide some real benefits. We just tweaked the molecule a little bit, and that made a difference in terms of adverse effects, for example.
Right.
But the thing is,
so there can be advantages to these kinds of things, but the problem is that when there aren't clear advantages, these drugs are still being heavily pushed.
and, exactly. And the problem is, if you have a system that says, well, even if it doesn't bring any therapeutic benefits, we still accept to pay 10 times more for this drug as compared to other drugs that already exist doing the same thing, then you're incentivizing this type of no innovation. And that's a huge problem.
That is a huge problem. I want to go to Blue for our next question.
So, just before that, something important maybe is to remind that, when we talk about patented drugs in Canada, we look from 2018 to 2021, according to the Patent and Medicines Price Review Board. It's 87% of new patented drugs. I'm not talking about generics, about new patented drugs coming to the market that did not bring any significant therapeutic advance as compared to drugs that already
87%.
exist. So we created this business model based on, let's pay a lot of money for crappy stuff, basically. And that's a huge problem. If you want a system that works well, so you need to say, we can accept to pay a lot of money for drugs if these drugs bring a lot of therapeutic benefits for a population. This is not what we're doing.
So we've outlined kind of two problems here. The first is Canadians need Pharmacare because of the fact that we don't have universal coverage. But the second is that Pharmacare must make sense. The way we've done it right now, we've incentivized $1 billion industry that is not providing therapeutic benefits to Canadians. So that's a huge problem. But Mr. Gagnon, I just want to make sure that we get a chance to ask all our questions. So I'm going to go to Blue now with our next question.
Thank you.
Great conversations. I think we touched on a lot of good points, and we already touched on some of the next questions I'm going to ask. But to make sure that our listeners can really understand this point, because some people might be hesitant about the idea of universal pharmacare, arguing that it could lead to a higher taxes as the government would take on the responsibility of paying for the drug instead of employers.
Thank you, Blue, for this fantastic question. Because I've been hearing this argument so much. Oh, well, that will increase our taxes. And, I don't understand. Working in public policy, when somebody says we need to lower taxes, what they're saying is that we need to increase disposable income for Canadian households. That's the purpose of lowering taxes. The thing here is that we would have a system that is costing less overall for Canadians. We're paying for drugs one way or the other, through taxes, through social insurance premiums, through private premiums, or out of pocket. But in the end, it would be a system that would be saving 20% on the cost of our drugs. And this is 20% that would be saved by Canadian households. So in the end, universal pharmacare achieved the exact same results than lowering taxes. It will increase disposable income for all Canadian households.
That makes perfect sense. And it obviously sounds like that's a big argument that we got to get rid of this one point. This point is crap. The idea that we raise taxes, but somehow we have a net loss to Canadians that doesn't make sense under a properly implemented Pharmacare model.
Exactly. And another argument that we've been hearing a lot, and for me, these are just lies. I mean, this is disinformation, but this is disinformation that is very useful because you want to create resistance against the implementation of a more rational system. So another element of disinformation, it's not about taxes, it's about, private drug plans are more generous. They're covering more drugs than the public plans. So if we introduce universal pharmacare, then we will have less generous coverage. People will lose their coverage. This is bad. No, absolutely not. Well, if what was on the table was something about, well, let's make illegal private drug plans and force a public drug plan for every. That's not the point. The Hoskins report, like I said, a very realistic and prudent way to implement universal pharmacare, but in a way that, okay, we start basically providing coverage for the whole population without replacing current private coverage. So basically, the implementation of universal pharmacare we're talking about with the Hoskins report, the Hoskins recommendations, what it would lead basically would be to decrease the cost, the financial burden for private health benefits. So that would mean that the employers and employees would have a bit more flexibility margin basically to decide, okay, well, we have more money, we can put this to maybe even improve even more the health benefits for employees. So other types of health benefits, blah, blah, blah. Or instead of having more health benefits, okay, well, maybe we can increase wages for the workers or just increase profits for the shareholders of the company, whatever. You can do whatever you want with this. But nowhere we would be taking away the coverage, the private coverage people have. Basically, what we would be doing is to just reduce the cost of this current private coverage for these people by organizing a rational system that is covering the whole population for a basket of essential medicines that will be growing over time into a comprehensive coverage for all the necessary drugs, basically, all the drugs that do bring therapeutic advance. So if in 10 years, an employer still want to provide coverage for drugs that are not proven to provide any therapeutic benefits as compared to what already exists, they can do whatever they want. This is a private employer with the employee. They can provide privileges. Oh, well, we'll give you, Ozempic, even if you don't have the diabetes. We will put, Viagra on the reimbursed drugs. You can do whatever you want. These are privileges employers can provide employees. But when it comes to essential healthcare services that are necessary to increase the health results of the population, this has to be done at the public level on the whole population as a right for citizens to have access to these medicines.
That's a great point. I kind of want to go back to one of the earlier points that you have mentioned, that you have stressed that one of the main issues with the current healthcare system is its fragmentations. Can you help our listener understand why this fragmentation is problematic and how it impacts Canadians seeking Medicares? And what changes do you believe could help address this issue and create more cohesive healthcare system?
This is an excellent question. I mentioned the system is fragmented, so different stakeholders can game the system. So that opens the door basically to the ghost management strategies by drug companies, insurance companies, etc. But also by governments in this case. So, the issue of confidential rebates is always a bit complicated because the thing is, we cannot say, oh, well, we need to get rid of confidential rebates. This is not happening. This is the name of the game right now. Everybody is doing that. We're kind of stuck with this. But the thing is, let's try to do this in a rational way that is protecting all Canadians, containing cost for all Canadians. In a fragmented system, basically, everybody can play the game by protecting themselves and just shifting the financial burden on somebody else's shoulders. So just to give you an idea, let's take a drug that reduces, not a statin, but a drug that reduces cholesterol called Repatha. So for people with specific genes, statins are not doing a good job at reducing cholesterol. So we have Repatha. The listed price for Repatha is $6,048 a year.
That's a lot of money.
Yes, and the thing is, there's a cost, an opportunity cost, basically, that you can measure with other drugs. And basically, for the therapeutic benefits this drug bring to the market, there's very little justification to have such a high price. So CADTH, once again, the Canadian Agency for Drugs and Technologies of Health, arrived with the recommendations. A price reductions of more than 90% will be required for the incremental cost-utility ratio of evolocumab, which is Repatha, to fall to $50,000 per quality when compared with statins alone or ezetimibe plus statin. The point here is that what CADTH is saying is that, okay, to reimburse the drug in a way that makes sense, you need to get a rebate of at least 90%. And normally, these recommendations are being followed. Right now, Repatha is reimbursed by every public drug plan. So we can assume that every public drug plan managed to obtain this confidential rebate of 90%. Now, fragmented system, how do we pass the buck with this? So, official price, $6,048 a year. The real price, let's say $605 a year. Now, let's suppose somebody adult annual income of $50,000 a year. Now, if you're insured by the public drug plan in Quebec, you need to pay deductibles monthly. You need to pay a 33% co-payment.
Okay.
But what is important, you're paying a 33% co-payment based not on the real price of $600 a year, but on the official price of $6,000 a year.
Wow.
Okay.
So, but there's a maximum contribution in Quebec somebody can pay. So the maximum contribution would be $1,200. So somebody in Quebec that needs Repatha, so first, they need to pay a premium of $731 a year to be on the public drug plan. And they would have to pay out of pocket $1,200 for a drug for which the real price is $600. So
that's how they make their money back.
So you can call this drug. I mean, this is a bit of an extreme example, but this is not drug coverage. This is simply a scam. But this is a scam. Every time you're paying more, keep in mind the rebate goes not. So when you're paying more, the difference does not go in the pockets of the drug industry. It goes in the pocket of the public drug plan, and that's a huge. So, okay, well, this is Quebec, but the other provinces, so Ontario is doing a bit better. They have normally a $5 dispensing fee that needs to pay out of pocket for every drug, for every prescription, and that's it. So if you have a fee that is not connected to the official price, basically...
Well, it's flat. It can't change, right?
Exactly. So the problem kind of disappears, but... in Ontario or British Columbia, you do have what we call catastrophic coverage. So for people who are not that do not have drug coverage, well, you need to pay more or less 4% of your annual income in prescription drugs, again, based on the official price of the drug. So you're not covered. You need to pay the official price. You don't have access to the rebate. And normally, this is mostly precarious workers that end up in this situation until you pay 4% of your annual income. But before you can get some subsidies by the state to help you buy your drugs. So if you're paying 4% of your annual income is $50,000 a year. Well, for the same Repatha, you'll be paying $2,000 a year to get a drug. You'll be paying out of pocket $2,000 a year to get a drug that is only $600, the real price.
And it seems like who is penalized by this the most are exactly who you're talking about, people who are not working in positions that have healthcare coverage to begin with. These are the people who often are facing precarious work and employment situations, and now we're penalizing them on top of that.
So, exactly. So this is one of the issues. But okay, let's say, well, I have private health benefits with my employer, so I'm just paying 20% of the price out of pocket. So if you're insured by a private drug plan with only a 20% copay, so you're still paying $1,200 a year to get $1,200 a year to get Repatha. But the thing is, this is what you're paying out of pocket, $1,200 for a drug that is costing really $600. But your employer needs to pay for the rest. The private drug plan did not negotiate the confidential rebates, so your employer needs to pay the additional 80%, so $4,800 that you will still have to pay as a premium to your private drug plan, basically.
Right.
So you have a system where, oh my God, private drug plans, in fact, are so useful for public drug plans because it's a fantastic way to shift the cost on them. And again, these are confidential rebates. So in Quebec, for example, like I said, as soon as the public plan accepts to reimburse the drug, private plans need to reimburse the drug as well, even if they do not get the confidential rebates.
Right.
The thing is, okay, if instead of negotiating a 90% rebate, I know that half of my market will still be paying for the drug at full cost, at full official price. The thing is, I can negotiate with the drug company. Well, you wanted to have access to the market, to the Quebec market? Well, give me a 100% rebate. What the heck? Give me 110% rebate. Give me money, and then the private payers will be paying full price on this. And keep in mind, the confidential rebates are negotiated. You have people around the table. If the two stakeholders around the table, the public drug plan and the drug company, as an incentive to artificially inflate the official price in order to give confidential rebates under the table, that's a huge problem. This is dysfunctional, and this is why we see so much resistance from different provinces. They're kind of scared that a more rational system will make things more complicated for them to just pass the buck around in the system.
So there's an incentive for provinces to almost push back against that, despite the fact that, in theory, this makes more sense.
Absolutely. So yes, everybody wants the better health benefits for the whole population, better health results for the whole population. But when it comes to dollar signs, basically, and who's holding the purse, well, we want to keep these strategies very simple to pass the buck around.
So at the end of the day, the implementation of Pharmacare is about kind of untangling a web of influence and looking at who is benefiting from the current system and how they're benefiting. And then also thinking about, of course, well, if all of these people are kind of getting it pretty good the way that it is now, what are they doing in the background to make sure that universal Pharmacare, once it's implemented, will continue to give them that same advantage?
Absolutely. And what they're doing behind the scene, I mean, I've been reading so much crap from the Fraser Institute, for example, the Canadian Health Policy Institute, which is a bit the same thing, the Fraser Institute. So let's keep in mind that the Fraser Institute was funded at first by the treasurer of Pfizer International. She was called the godmother of all think tanks. That was her job, basically, creating think tanks everywhere to support the demands of drug companies in different countries. And the thing is, you have these think tanks that do produce very dubious research and try to make this look as if it was a good peer-reviewed research. This is not the case. It's just, and this is very important. When you're reading any study on these issues, go have a look at who is funding this. What are the conflicts of interest of the authors behind this? Because that's the thing. I'm working in health policy, social policy. We've been working on so many different issues, but when it comes to Pharmacare, there's so much money involved, basically. So like I said, the issue is $7 billion in savings we could have. So 7 billion other stakeholders will be losing. They will do everything they can to make sure it's not happening. And this is the situation we have right now. And if we continue this whole system of disinformation that is being relayed politically by some parties, sometimes we cannot get out of this, and we need to just start building a rational system that covers well, provide value for money, and promote a more rational use of medicine for the whole population. Right now, we have a system where all the incentives is, let's give the maximum amount of pills to everybody, whatever it is, for whatever reason. And that's not working.
And as you've laid out for us today, that causes real damage.
Absolutely.
So, thank you very much for kind of explaining that for our listeners.
Thank you so much, Professor Gagnon, for joining us today and addressing all of our burning questions about Pharmacare. And to our wonderful Ghost Management podcast listeners, we appreciate your support and subscription. Until next time, take care.
Take care.
Thanks, everybody. Thank you for listening. Please follow us online by registering for our website's newsletter at carleton.ca/Ghost Management. You can also follow us on Twitter. Our handle is @GM Research Group. Our musical theme is Hablando por Hablar by Alex Cuba. The Ghost Management Research Project is funded through an Insight grant from the Social Sciences and Humanities Research Council of Canada and its initiative for digital citizen research. The funders had no role in the design, conduct, or publication of the content. Thank you for your interest, and we'll see you soon.